I want to introduce our first speaker. Holly Wilcox is an associate professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. She also has appointments in the Department of Health Policy and Management, as well as the Schools of Medicine and Education. Her work deals with population-based research on suicide behaviors. And so we are going to have her talk about suicide trends, suicide incidence rates, how that has changed over time over the last decade or so. And then we will go to David Gunnell to be talking about COVID specifically, talking about suicide during pandemics and economic downturns. Then we'll go to Alfie Breland-Noble to talk about accessing mental health services and disparities in that. So for now, I want to turn it over to Holly, and we'll call up your slideshow and turn it over to you, Dr. Wilcox.
Hello, everyone. It's really a pleasure and honor to be here with you today. Next slide, please. I'm just going to talk a little bit about the United States context in terms of suicide. And here you'll see the leading causes of death in the United States. Suicide is ranked 10th overall, but is second for younger people. Many of these causes of death have leveled off or decreased in the past 10 years or so. Suicide, however, has not. And the other one that hasn't is influenza and pneumonia. Next slide, please. This slide shows you some trend data looking from around the time of the Great Depression to present. One thing I will point out is that the most recent data that we have available nationally is from 2018. There is a lag in being able to obtain those data from each of the states and organize them and make them publicly available. So this is something that our federal government and other governments have been working on is this lag, and trying to be able to use this data that are intended for surveillance for more current crises like the one we're experiencing now. So here you'll see the rates for males and females. Males die by suicide at a rate that's at about a 3- to 4-fold increase as compared to women. They're more likely to die by suicide, but women are more likely to be treated for suicide attempts. And by looking at the trends here, you can see that within the past couple decades, the suicide rates have been steadily increasing in both men and women. And you may be wondering why and what's driving those trends. And we don't have a real solid understanding in the United States of what's driving those trends, although we're working on getting data to better understand them, like the National Violence Death Reporting System by the CDC, but they're not really well understood. Some of the factors that have shown some evidence or are hypothesized to be associated with that are potentially cohort effects. There are some generations that have a higher proportion of risk factors. And for suicide, some of the largest risk factors are mental health related and social related risk factors. So it could be cohort effects with higher mental health burden or social burden in certain cohorts. There's a hypothesis and theory that has gotten a lot of attention in the United States, and it was put forth by Princeton economists Ann Case and Angus Deaton. And this, their theory behind it is that the economic impacts over the last 10 years or so have affected the suicide rate. And their work is really focused on what they call deaths of despair. So these are deaths that are alcohol related, drug related, or are related to suicide. And they put forth that this has been an issue. You know, the economic impacts have been very harsh, particularly on some socioeconomic subgroups, like middle-aged white men who have a high school education or less. Also, social media sometimes gets a really bad reputation in terms of thinking about suicide. We don't fully understand the impacts of social media and how it relates to suicide. What I've seen is sort of pluses and minuses depending on the individuals of focus. Another factor that could be contributing is the black box warning, which was a warning put onto the prescription of antidepressants, and that was around 2004. And so there may be some doctors that are less likely to prescribe antidepressant medications because they could be worried about the risks associated with these. The other thing to keep in mind is there could be better reporting more recently on suicide. Suicide is really hard for a medical examiner or coroner to determine, because oftentimes they're looking for intent. Was there intent? If there's a note, that is clear that there was intent, that that person intended to die by suicide. But if there isn't a note at the scene, the investigation often, they compile different pieces of information, and sometimes it's not completely clear if it was a drug-related death, whether it was a suicide or accident, and so forth. So the classification of suicide there could be differences over time in the recording of suicide deaths. Next slide, please. So this shows you some variation of the rates by state in the United States. And here you see in this bright orange color, the states that have had the highest rates as reported in 2018. And there is, as I was talking about the variation over time and what could be driving suicide, there is variation across the states. And you may be wondering what drives the suicide rates. And again, I wish I could say that we had more concrete information on what drives them, but we don't have a clear understanding. But what the factors that we think could be driving these differences are firearm ownership, which in some states is high. Also ready access to mental health services. Some of these states with high rates are very rural. Think about Alaska, and it may be hard to access mental health professionals. There are social and economic factors that also could be associated with differences between states. Mental health stigma is often a real big barrier to suicide prevention and people getting the care they need when they're in crisis or just in general. Also factors such as economic instability, educational opportunities, work opportunities, all of those could factor in to differential rates across our states. Another interesting hypothesis where there is some emerging research on this is altitude. So you see those states along the mountain region with higher rates, and there is some work showing that people who live at high elevations could have less oxygen getting to their brain, hypoxia. There's not a lot of evidence supporting that, but it's an intriguing thing to consider in terms of influencing rates. The other thing to keep in mind is the different population groups living in these states. So Native American populations differ, and many Native American populations live in these states with higher rates. Native Americans are at higher risk. At least young Native Americans are at higher risk in the United States. That's one of our highest risk groups. Also, veterans are another subpopulation with high risk. About 20% of our suicides in the United States are by veterans. Next slide, please. So what can we do to prevent suicide? In general and in this context, I find that the CDC technical package of policy and programs is very good, and it has high implications for what we can be doing now in our states and in our settings in order to be more proactive and better at suicide prevention. Here, I'll just quickly talk about a few of these. The first one, provide technical and financial support to individuals in need. That's an important one that the CDC points out. Delivery of access to care through telemedicine or outreach, creating protective environments, thinking about lethal means, and about alcohol misuse during this time, and others here. Skip to the next slide, please. And one of those recommendations from the CDC has to do with monitoring risk or reducing risk for those who might be vulnerable. And the WHO and the American Foundation for Suicide has put out some really great guidelines. And I just wanted to bring this up to you as a resource. Just to point out a couple things. Try not to use the word committed. People who have survived family members' suicide often think that this is kind of like a criminalization of suicide when the word committed is used. So try to drop that from that word from your story. Also, when you're presenting about suicide, please always try to include the National Suicide Prevention Lifeline number and the crisis text line if you're in the United States. And there are I'll stop due to time right now, but there's some other really useful recommendations. And the thing that I will point out is that the American Foundation for Suicide Prevention has Alexis O'Brien, who's terrific, who takes calls from journalists and can help with stories. And this is really important because vulnerable people who are reading your story, it could influence their risk. And so being cautious and following these guidelines could save lives. And there's plenty of research backing that. Thank you so much.
Okay, we do have one question. Tyler, if you could just go back to the state slides. And Holly, somebody is asking, Esther Dyson from executive founder of Wellville is asking about the rate in Illinois, and it also looks like Delaware are this dark gray. Do you happen to know where they're supposed to be on that chart?
Oh yes, something happened with my slide. I believe, yeah.
Okay.
I would have to get back to you about that. I can distribute to the whole group information about each state and their rates. I'm sorry about that. I think when I sent my slides, it changed the colors.
Okay. All right. Well, just so you know, and for all of our viewers, all of the resources, the slideshows we're seeing right now, as well as the guidelines from the American Foundation for Suicide Prevention, the media guidelines, the CDC information, also information from the WHO and from the National Institute of Mental Health, as well as various articles that are relevant to suicide and mental health in general, or COVID and suicide specifically. All of those will be posted on our website after our program. So the full audio of the program, the full video of the program, a story about the program, and a bunch of resources that we think will help you kind of get up to speed quickly on the topic will all be posted on our website by the end of the afternoon. One question right now, and then we'll turn it over to David. David Abell from the Boston Globe.
Great. Okay. Well, thank you all. And I'm sorry I've harassed each of you by email. I'm working on a story about the subject, but thank you so much. And I imagine you'll be getting to this. But I wonder if you could just talk about a bit what we should expect from COVID, given everything that you know about these trends, and what are your bigger concerns here in terms of what might fuel a rise in this. And also, conversely, as I mentioned in my emails, we in Massachusetts have, according to preliminary data at least, have seen a substantial decline in suicides in March, and compared to the historical average over the last 20 years. And maybe you can share a little insight what might explain that.
So I'll just say briefly that I will get to some of the conversation around disparities and how looking across racial cultural groups There are considerations that we want to be mindful of. So if there's one thing that I hope we don't lose in the conversation, as you asked, it is that we don't lose sight of what some of these disparities are, particularly when we think about, I happen to be African-American, but when we also think about the disparately negative impact that the virus has had on African-Americans. But again, I will speak to that. And you couple that with some of the research that has come out about about the rising suicide rates. I'm thinking about Dr. Wilcox's advice among certain populations of African-American youth, boys in particular. So I will cover some of that, but I'll let my colleagues speak to some of the other questions that you had.
So I know that David's going to talk some more about this issue, but it's not surprising during the time of different disasters and different events such as COVID that the rates decrease a bit. It could be because of people coming together. It could be one silver lining is that this has brought people together. But if there is prolonged stress economically and socially, and if we can't try to work towards reducing stress for people, we could see an increase, but we don't know that we will. I think we have to be really cautious about this issue and how we frame it, because we don't know for sure that we're going to see an increase. And in terms of sometimes it takes a while to finalize the death data. So sometimes you have to wait a little bit to make sure all the data are final in terms of the death classification. There could be people who are found in the woods, or, it could take a while to kind of capture the full, I mean, that sounds kind of graphic, but it's, these are things that they deal with, medical examiners. It could take a while to figure out the full burden of suicide within a setting.
Just from a UK perspective, the average, if you look at international figures, oftentimes the average delay between a death by suicide occurring and it being formally registered in our national statistics unit is about 6 months. So, but I'll say a bit more about it.
So I think that since this is what David is going to be talking about, I think where you can call up his slides, and I'll give a brief introduction to David Gunnell, who is an epidemiologist and suicidologist at the University of Bristol. He's one of the leading experts on understanding causes and trends behind suicide. And I came to him last week after an article that many of you may have seen in The Lancet Psychiatry, that the headline "Suicide Risk and Prevention During COVID-19 Pandemic," and it's very important for people to access, and I'll have a link to this on our resources. But basically, it's talking about how there are suggestions that suicide rates will rise, although that's not inevitable. And so I think, so David Gunnell is going to talk about what we've seen during previous pandemics, what that evidence was like, how strong it was, and whether it's likely that there will be an increase or whether it's just possible that there will be an increase, which I think is the basic journalistic question that many of us have. So I'll turn it over to David right now.
Thanks, Chris, and good morning, everyone. I join you from the southwest of England on a very damp and rather cool evening, but it's a great pleasure to be speaking to you today, so thank you. I'm going to be talking about three things in my talk. I'm first of all going to put concerns about suicide in the context of deaths occurring in the COVID-19 pandemic, so we get a sense for the relative numbers of deaths. I'm going to talk about particular concerns in the suicide prevention and mental health community about suicide. And then I'm going to end by summarising some approaches we might be thinking about taking now in our forward planning to mitigate against those risks. But just to build what others were saying, I mean, we're living now in extraordinary times, and it is just really difficult to predict exactly what's going to happen. We do know, as Holly has just so nicely said, we do know about a series of risk factors for suicide, and we know some that might head in a problematic direction. But it is hard to predict what might happen. But I think it's really important for us to be prepared. So next slide, please. So just to put things into some degree of perspective, I mean, suicide is perhaps the most tragic cause of mortality. And as Holly has already said, you know, it's the 10th most common cause of death in the United States. It's one of the commonest causes of premature mortality. Every year in the UK, there are around 6,500 deaths from suicide. In the States, that figure's over 48,000. You're a much bigger country than us. But that equates in the UK to 540 deaths per month. So put in perspective against the current circumstances we find ourselves in with COVID-19, in the last 2 months in the UK, we've had around 21,000 deaths compared to those 540 suicides. So the big problem facing us at the moment is dealing with COVID-19 and the challenges associated with that. You know, 20 times more deaths in a month from COVID-19 than from suicide. Similarly in the States, over 48,000 suicides, 4,000 a month, compared to 28,400 deaths in the last couple of months from COVID-19. So you know, an order of magnitude in difference between these two causes of death. Okay, next slide, please. So what do we know about the impact of pandemics or epidemics on suicide rates? And the short answer is we don't know a whole lot. One of the best papers, I think, looking at this was published around, well, over 20 years ago now in the American journal Suicide and Life-Threatening Behavior. And it was written by an American sociologist, Ira Wasserman. And what he did was he mapped trends in overall mortality against trends in suicide between 1910 and 1920, a period of time when the Spanish flu pandemic hit the United States. And one of the most striking things you see on this slide is the peak in overall mortality that occurred, first of all in 1918, towards the end of 1918, and then secondly towards the end of 1919. On this slide, the two lines show trends in overall mortality and trends in suicide mortality. It looks like the rates for the two causes of death are similar, but you need to bear in mind when looking at these trend rates that the suicide mortality rates are rates per 100,000 people, whereas the overall mortality rates are rates per 1,000 people. So the slide or the chart was rescaled simply so you could look at the timing of changes in suicide alongside changes in overall mortality. So the other thing you'll see if you focus in on the period of the pandemic and that greatest peak in overall mortality from the pandemic was the possibility of a slight rise in suicide in the months after the pandemic, a slight upturn then, short-lived, but it's noteworthy that the suicide rates at that time were lower than they were in previous years. But in a thorough statistical analysis taking account of factors such as the First World War, trend in unemployment and media reporting, there was some statistical evidence for a rise in suicide in the period shortly after the pandemic. Data from Hong Kong, more recent data from Hong Kong, looking at the SARS epidemic there in 2003, provides some evidence for rise in suicide rates amongst the elderly around that time, something like a 30% rise. So what limited evidence there is provides an indication that of a possible small rise in suicides, but the number of suicide deaths is far outweighed by the number of deaths associated with these big pandemics. Next slide, please. So what are the things that concern those of us working in this field? What are the kind of concerns in relation to the general population, and what are the concerns in relation to particular clinical populations? So the things that concern us, the impact of social isolation from physical distancing, the stresses that healthcare and social care staff and other frontline workers are under during these difficult times. We're concerned about possible rises in domestic violence from people living in lockdown in closed environments without no capacity to escape. We're concerned about rises in alcohol misuse. There's some suggestion that might happen. We're perhaps particularly concerned about the economic impact of public health responses to COVID-19. There's really good and consistent evidence that periods of economic recession are associated with rises in suicide. So that's one of our concerns, making sure that there are safety nets in place for people who are struggling financially or who lose their jobs. We're also concerned about interruptions to young people's education, both at school and at university. Concerned about people who lose loved ones through the crisis and the difficulties going through the grieving process, particularly now where conventional approaches to celebrating their lives are just not possible. And we're also concerned, as Holly has highlighted, about media reporting, about making sure that it's in a balanced way and doesn't increase the risk of suicide occurring, because that's a big concern in our suicide prevention community. Next slide, please. So now turning to clinical populations. So one of the big challenges faced now by people working in mental health care is carrying out assessments of suicide risk in non-face-to-face settings. Now, how do we, we're used to seeing people in our consulting room face-to-face, we can get non-verbal cues. Now that becomes more difficult to us. So we're concerned about how we carry out reliable assessments of risk to people. We're also concerned that some people who make suicide attempts or who self-harm may be deterred from attending hospital or seeking help because they're worried about catching the virus if they go to a healthcare facility. So what can we do to make sure those people who are particularly distressed are receiving appropriate healthcare? We're concerned about stigma from amongst people recovering from COVID-19. And we're concerned about challenges ensuring that there are adequate staffing levels in mental health hospitals and on national suicide crisis lines, because interruptions in services means that oftentimes these services are more difficult to run and provide people to serve. Next slide, please. So I won't talk you through this slide. This is taken from our Lancet Psychiatry paper that Chris just mentioned. It essentially provides a roadmap of some of the important issues in suicide prevention. It provides a list of things that governments should be thinking about, the mental health services should be thinking about, communities should be thinking about, the media should be thinking about in terms of mitigating any risk arising from the COVID pandemic on suicide. So there's a series of suggestions there. And in my last slide, I'll just flag up a few of those suggestions and perhaps we can talk about them more during the discussion. So last slide, please. So the sorts of approaches that we're recommending are things such as developing clear care pathways for people who are suicidal and guidance for clinicians, frontline professionals, on how best to carry out remote assessment of risk. The provision of good staff training to support them in their new ways of working. Support for our healthcare staff who are in the front line dealing day in, day out with very difficult circumstances, experiencing high numbers of deaths amongst the patients they care for. I mentioned the concern about recession, so it's really important governments should be thinking about the provision of financial safety nets for the more marginalised people in our communities, but also anyone who loses their jobs or whose income has become insecure. And those sorts of labour market programmes that they might put in place include things like helping people seek work, developing apprenticeship schemes, providing subsidised job opportunities for people. Lastly, providing accessible help for people who have lost a loved one, helping them through the bereavement from the virus, supporting crisis helplines, and enhanced surveillance for emerging stresses. So one of the big things we need to be doing in the public health community is looking at what's happening to trends in suicide deaths, what's happening to trends in suicide attempts, and what are the stresses that might be leading to any adverse trends. And by identifying those stresses at an early stage, it will enable our policymakers, our clinicians, our governments to respond in a timely fashion. So Holly's already highlighted the challenge with suicide death statistics. They often lag some way behind deaths actually occurring. So a lot of us are thinking very carefully, well, how can we get early insights into those figures and how can we use those early insights to inform our changing prevention strategies? Okay, last slide. Thank you.
So, as I said, if you have a question to ask, raise your hand and we'll get you in on an audio question, or send in your question via text and I'll ask those questions. I do have one question. I think it's maybe primarily for Holly, but I guess any of you can deal with it. This is from Carol Morton from the Milwaukee Journal Sentinel. what efforts are happening to improve timely and better data in different places? Dr. Wilcox, you want to take that one?
Yeah, I can take this one. I can start anyway. Well, this is a priority. The National Action Alliance for Suicide Prevention, which is a public-private coalition in the U.S. of people who've come together to try to enhance and make our efforts nationally in the U.S. better. And so there have been some efforts to try to access data better. There's the National Violent Death Reporting System. There are many more states that now are part of that. I think almost all states now are part of that program. And so that's collecting more data on the causes, potential causes, or the circumstances that are associated with violent deaths, such as suicide. So there's more of an effort to get better coverage and to get those data available more quickly. The one way that you can best try to gain access to more timely data is to work with your public health professionals within your county or your state or your jurisdiction where you live. Oftentimes the medical examiner communicates data directly to public health officials, and so they will have access to data that the general public will not. And so David earlier was saying that he was able to access some data from Massachusetts on deaths recently, suicide deaths. And so I believe that's the mechanism that he took to be able to access that more timely information. And so I'm not sure if that's fully answering your question, but there are issues with the classification of the death. It takes time. And then making sure those data are prepared and ready to be transferred to the federal government is another level of work that has to be done to make those data publicly available.
So we're going to hear next from Dr. Alfie Breland-Noble. She goes by Dr. Alfie, and she's been a speaker for us at the National Press Foundation for our in-person trainings in Washington. She had a long academic career at Duke and Georgetown, and now is with the nonprofit, the ACOMA Project. And she is going to talk about access issues and disparity in access and how that will impact mental health treatment going forward. She's going to talk for 6 or 7 minutes, and then we'll have time for a final round of as many questions as we can get in. So, Dr. Alfie?
All right, thank you so much, Chris, and thank you to the National Press Foundation for having me back. This is a really important topic, and it's very timely, particularly given the news that we've seen in the last couple of days. And so I always start off by saying that one death by suicide is one too many. So I always want to put that in context, that when we start talking about large numbers, I think sometimes it feels like we may lose sight of the fact that the people who are dying by suicide are attached to families and communities and workplaces. And so we always want to acknowledge that we all understand that one is too many. I'm going to talk about 3 primary points. As Chris mentioned, these are all under the auspices of the thinking about disparities in access to care. I don't have a lot of slides. I think this is the only slide that I have. We want to change things up just a little bit. So within the context of disparities in access to care, I want to make sure that I end on a note providing some ideas about what can providers, communities, clinics, all types of entities, what can they do to support access to care under these, as my colleague, Professor Gunnell said, unprecedented times. So when we think about disparities, we want to think about 3 things: disproportionality, right? How the crisis itself, the illness, the virus is impacting different communities differently. We want to think about access to care or lack thereof. And then there's one idea I think it's important to remember, which is this idea of the trauma that's associated with the first 2 and how that may exacerbate some of the issues as we see the crisis continue. So when we think about disproportionality, part of what comes to mind to me is a lot of the reporting that we've seen in the news about, and it's important reporting about how different communities, whether that's socioeconomic differences, whether that's racial, ethnic differences, are being disproportionately impacted by the actual physical illness itself. And then what are the resulting ramifications related to who's getting sick and who's dying from the illness itself. So I think it's important to really be mindful that it's critical that we examine these ideas. Professor Gunno mentioned them in a long list on one of his slides, and we call those things social determinants of health, right? We cannot lose sight of the social determinants of health. So who has access to physical care when they get ill? Even when a person gets into care, what are the disparate impacts that the stimulus of their race or ethnicity, notice I didn't say that because of their race or ethnicity, it is how people respond to race and ethnicity within the context of the healthcare system, right? Which we know in the United States has a very up and down kind of history. When people get into care, how are they treated, right? Who has access to the best resources once they get into care? And then who's dying more by the illness, and how are we reporting that, and how much are we seeing that? So I feel like that's one really critical thing that we have to pay attention to, and think and be mindful of how the disproportionate negative impact of the illness is impacting people's mental health, people who come from these communities, people who are in professions, right? We think about service workers, and which racial cultural groups are overrepresented in the service work field who have more exposure to the illness, right? So we have to be mindful of all these kinds of things when we're thinking about mental health in general as it relates to the illness. So we put that under the label of disparity. So part of what I want to communicate is that it's really important that we not lose sight of how disparities in general with the physical illness then generate or contribute to disparities related to mental illness, and then thinking about suicide. So along those lines, we want to also be thinking about access to care and or lack of access to care. And what do I mean when I talk about lack of access to care? Well, part of the first thing that many of our minds go to is who has money to pay for it. That is a part of it, right? That is a big part of it, but it is not the only factor. Because for many communities of color, even when they have private insurance or money to pay for care, I as a member of one of these communities, are much less likely to seek out mental health services for a myriad of reasons, right? That predates the COVID crisis. What the COVID crisis does is it exacerbates the problem, right? So if you're already in a position where you think about people, your loved ones, people in your community who are more likely to be sick, regardless of socioeconomic status. Again, we saw a report in the news, I think it was just yesterday, that one of the wealthiest Black communities in the country, Prince George's County, is being ravaged by the illness. And these are African Americans with means and resources, right? Which theoretically means they should have access. Yet the illness is still ravaging this community. So when we think about access to care, there are all kinds of issues around mistrust of the medical profession in general in certain communities in the United States. There are all kinds of issues around what is the lived experience when people go into care, right? And what do people come back to the community and report about what their experience was in care? And so if you think about the messages that are communicated, people's real lived experience, this idea of lack of access to care goes beyond just whether or not I have the means to pay. So what's really important to me is that when we're reporting and talking about these things, we are mindful of people making conscious choices to not go into care and the reason they're making those choices, and that we not vilify and demonize folks for making these kinds of choices, but that part of our role, which is part of why I'm on this call and doing this briefing, is to make sure that we're putting these things in context so we have a strong mechanism for trying to disrupt the narrative, right? And help people get into care. We want people to feel like there's a place for them in care. We want people to know that they don't have to be necessarily completely overly concerned with are they gonna get good care or not. And so we have to make sure that when we're asking people to go into care and to ask for help, that they're going into places where the providers are cognizant that these are some of these folks' worries, so that part of their job is to alleviate some of those concerns and work overtime to make sure that people feel welcome and supported in these environments, right? So it's a two-way street. I think, thirdly, we want to think about the trauma that comes from the overrepresentation among those communities of people who are negatively impacted, and the trauma that comes from the lack of access to care, whether that's financial, which is a small part of it, whether that is the negative experiences that people have when they go into treatment, and whether that is the reporting that comes back to the community when people go in to seek care. So when I'm thinking about trauma, what I'm thinking about is, go back to this idea of social determinants of health. let's think about the ways in which, if you are already besieged by all kinds of other things, racism, discrimination, issues around xenophobia, if these things are negatively impacting you, is your mental health necessarily your first priority? Probably not. Your physical health is your first priority. And so what we want to do is be able to communicate the message publicly that it is just as important to care for and address your mental health, because you don't want the negative downstream outcomes, right? One of which might be dying by suicide, that come from not addressing your mental health as adamantly and as vigorously as you address your physical health. So that's one piece. I think another piece is thinking about the ways in which physical distancing, I think we're getting away from the social distancing term, but physical distancing impacts your ability to make use of those culturally rooted, culturally centered norms and mores that serve as supports and buffers for your care, right? So I think about the stories where people are not able to go to church. In many communities, particularly African American and Latinx communities, the faith community is like the social hub. But what happens when you no longer have access to that social hub? That has negative downstream impacts on your mental health. And finally, thinking about the ways in which cultural norms are disrupted again by the illness and how that then can contribute to trauma. I think about the stories we've read where family members are not able to bury the people they love because of the COVID crisis, because they can't come out. And so I think part of what we have to be cognizant of as mental health providers, as people who are reporting on these issues and as systems, is thinking about innovative ways. Professor Gunnar and Professor Wilcox mentioned some of these. What are innovative ways that we can create to support people to ensure that their mental health is being addressed, that it is a primary area of investment and interest for individuals and their communities? And so how do we communicate that, and what can we do? So the final thing I'll say is that telehealth really is where we are right now. This is what we have to work with. And so we need to ensure that people have access to telehealth, right? We need to make sure people have access to Wi-Fi. We need to make sure that people can access apps on smartphones, right? Particularly for young people, because so many young people who are from communities of color, thinking of Latinx and African American Black children specifically, have access to smartphones. We need to normalize the process by which we ask these young people to make use of those smartphones to get the kind of mental health care that we need. We need rules that allow providers to practice across state lines during the crisis, so that if you're in a community that doesn't have a lot of people who are culturally competent or who reflect the race and cultural diversity and language diversity of a community, maybe the next county over there are some folks. And so these folks need to be able to practice across state lines. So I would say these are some of the things we want to be mindful of. And just in summary, we want to be thinking about the disparate impact of the illness on different communities. We want to be thinking about social determinants of health as it relates to access to care. And then we really want to be thinking about the final thing that I said, which is the trauma related to the first two, and how we report and begin to enact things that will reduce some of the negative impact on our mental health as a result of the physical health crisis that is COVID-19. And I'll stop there.
Okay, thank you very much, Dr. Alfie. So just a heads up for our viewers out there, it's 12 minutes until 1 o'clock Eastern. Dr. Wilcox needs to drop off the call right at 1 o'clock, but Dr. Gunnell and Dr. Alfie will be able to stay for a little bit past that. We'll get through as many questions as we can. And I want to turn the microphone over to Jason Chirkus. Jason, I know him from previous stints at the Huffington Post, and now I see he's working on a book about suicide for Random House. So Jason, you are unmuted, and you can ask your question.
Thanks. I wanted to just ask about telehealth. It was brought up twice in the sessions here. How, prior to the virus, how accessible was teletherapy, either through telephone, Zoom, electronic, or any of those things? How accessible was it? How accessible was it? Did states make it accessible? Did they allow for it to happen? And did insurance companies cover it? I've heard that there was a lot of pushback prior to the virus.
So I'll say I looked at a meta-analysis last night from, I think it was 2013, where they looked at telehealth. And then I looked at a follow-up meta-analysis, and they were, I just looked at how many studies there had been. And what I will say is this: for the number of studies in each case was less than 30. And then when I looked at the numbers of people who were included in the studies, none of those numbers were over 200 or 300 people. So I think that from my perspective as a clinician and a researcher, I saw telehealth growing. I do agree with you that there was initially some pushback around insurance companies paying for it. And for example, one of the things I noticed when I used to be on insurance panels was that sometimes panels would require you to use their platform in order to provide the care, such that you couldn't use Zoom or GoToMeeting or some of these other platforms to be able to provide the care. That in and of itself is a barrier because some providers might not necessarily have easy access to figuring out those new platforms that the insurance providers wanted you to use. What I will say is that since the crisis has happened, clearly there's been an explosion in the use of telehealth. And I think that that's going to have long-term downstream effects after it's over, because we're seeing that it can be quite useful. We're seeing that it increases accessibility. I think for communities of color, and particularly in underserved communities, it helps to reduce some of the stigma because nobody necessarily has to know that you're sitting in your house on your phone with your provider. And the other thing I will say is that you have this plethora, right? This proliferation of things, these chat features and text features like Talkspace and some of the other ones that I can't think of right now. Ayana therapy is one that is specific to communities of color and queer communities. So I think you're seeing a growth. I do think that COVID-19 has exacerbated the growth in ways that I don't know it would have happened otherwise. But I think that you're right. There was a little bit more resistance before. I think there's less resistance now. And I think afterward, there probably will continue to be less resistance. But I'll yield to my colleagues if you have other things to add.
I can't really speak from a US perspective, but I know I just echo that. I mean, there's been a burgeoning of interest in the development of apps, online therapies, and the COVID-19 pandemic has been a real prompt to get on with further developmental work. So it's from a big platform, and I think there's a lot of effort to get more material out there. I suppose just one note of caution, and there is so much out there. Some of it will be evidence-based, safe and effective. Others will be less well supported. So I think people still need to take care in selecting the package, or particularly if it's a self-help app, the package they use. In the UK, we have sort of particularly recommended apps that are recommended by NICE. You've probably got an equivalent sort of system in the States.
That could be one silver lining. One of the good things that came out of COVID is, I know that there's legislation that was passed in my state, Maryland, that would enable Medicaid and Medicare patients to receive telemental health through telemedicine. And so many other states may have done the same, but it was pushed through as part of emergency legislation.
So we have some text questions coming in. Let me get through some of these. This is one I know that's on top of a lot of people's minds today. This one is the question is from Laura Newman from California. Can you address the high-profile death by suicide of the ER doctor in New York City? This is something we talked about before the call that was written about in the New York Times and other places. What sorts of prevention strategies could hospitals adopt for frontline workers? And I'd like to add to that, how should the media be covering an individual suicide like this? Is it fair to treat it as a potential example of what might be the broader trend coming, or would you handle that? Oh, that's open to any of you.
Shall I start out? I mean,
sure.
Just a couple of points. And I think in terms of reporting, be very careful before you report on these deaths. Go and look at the guidelines, the fantastic guidelines that are there to guide the nature of your reporting. It includes issues like don't mention the method. Try not to assert. I mean, really tragic death. It was reported over here in the UK as well. But try to avoid overly dramatic headlines that may make people who are working in similar situations feel more vulnerable themselves. Oftentimes, if you have a report of a suicide amongst someone who's quite similar to yourself, experienced similar stresses, and you yourself are feeling vulnerable, that might heighten your risk. So just be really careful. I think in terms of what health systems can do to mitigate risk is providing support for people, recognising the stress that staff are under, making sure they're taking breaks, getting enough rest, and have got access to support services to talk through some of the very difficult issues they're facing on a day-to-day basis.
Okay, Ali or Dr. Alfie, any thoughts?
Sure. I think there's something to be said for thinking from a prevention perspective, rather than waiting until it's time for intervention. And by prevention, what I mean is I saw reports about the numbers of trainees or people right out of school who were being called in to provide support as medical professionals, nurses, physicians assistants, all types of folks. And I think it's important to recognize that somebody's fresh out of training, there are different ways in which we need to take care of them, right? Because they haven't been in these kind of situations. So we're really sort of taking them out of training and throwing them right into the midst of the fire. And so what we want to do is, for those kinds of populations, as well as for the people who've been out there for years, we want to be thinking about what can we do to almost inoculate people just a little bit. Like, you can't prevent all the stress that's going to come at people, but how do you bring them into the system in a way that's giving them some tools that they can use before they get overwhelmed with the deluge of stress and anxiety that's going to come at them. And so you need, in addition to what Professor Connell said, you want to be thinking about, in addition to giving people breaks, give them a space to take a break in that is away from, right, all the chaos that they're facing, managing how many hours people are working. I know these things sound like they're difficult, and that's usually what you hear. Well, it's too difficult, we just need to get everybody out there. But we also don't want to be putting people at risk unnecessarily, right? So it is, when you bring people in, having a conversation with them about, this is what you're going to be walking into. We need you to be mindful of when it's time for you to take a break, when you feel your body getting stressed, teaching them signs and symptoms of anxiety, teaching them signs and symptoms of depression, teaching them signs and symptoms of suicidal ideation, suicidal thoughts in themselves, so that they can self-regulate. I think what we often think is because they're medical professionals and they have alphabet soup behind their name, that means they automatically know how to take care of themselves. And I wouldn't say that that's necessarily the case. So the prevention piece, I think, is really key, and we have to be equipping people with the mental and emotional tools to walk into these stressful, trauma-inducing situations.
So I know, Dr. Wilcox, I know you need to drop off in a couple of minutes, so I'll give you first crack at this next question, because it's dealing with reporting suicide information, which we talked about before. This is from George Ayoko from Kenya. We've had cases of people leaving behind suicide notes before committing suicide. Is it advisable for journalists to rely on the information from those notes while covering the reasons behind the suicide? Do you have any thoughts on that?
No, I'm gonna let Dr. Gunnell take this one. I think
Sure.
I saw his reaction to this question, so I'll go ahead and let him jump in.
Gosh, it's a really tricky one. I think real risks in actually reporting the nature and the content of suicide notes, that can have cause real resonances and distress, I think. Also, I think you need to bear in mind, oftentimes when someone reaches that point in their lives where they're considering taking their lives, they're writing a note, that they're often very depressed. Often the way they're thinking about things isn't the way they might think when they're not depressed at brighter times. So sometimes the kind of impressions that are put into these suicide notes may not be the ones that are shared by other people necessarily. So I think I'd be very cautious about that. Often, the more it's often the coroners or the police inquiry following the death where family members and friends are spoken to, and you get a clearer picture of everything that might have contributed to the death. It's using that fuller information rather than perhaps the kind of knee-jerk reporting straight away on the first bit of information you see that might be relevant to the cause of the death. So all suicide deaths are complex, often multi-causal, many contributors. Sometimes in a suicide note, when it's written, you might see all those factors distilled down to one issue, when it's really much more complex than that. So I'd caution against drawing on those sorts of sources of information.
Another thing you may want to think about is the issue of somebody reading your story, if you're writing about the notes, them identifying with the decedent, the person who died, and concerns that they may be likening their situation to the decedent, the person who died situation. And so those are things that I would be worrying about in terms of using actual information from the suicide notes in your story.
I agree.
Okay. So Dr. Wilcox, I see your dog has joined us in the background. If you need
Zoom
to,
bombed us.
yeah, if you need to drop off, we thank you very much. I know you have to get to another call, but thank you very much for joining us and for sharing your expertise with us. It's very much appreciated.
Thank you.
But we do have a few more questions I would like to get to. But thank you, Dr. Wilcox.
Thank you.
Question from Mary Hines of the Las Vegas Review-Journal. Can you please elaborate on why, for the time being, suicides might be down? And if this is likely temporary, what's the time frame for when suicides might increase? Dr.
So I
Gunnell,
think a couple things.
Sure.
Yeah. So I think a couple things. I think, as was said earlier, that the lag time between, I think Professor Gunnell said it earlier, the lag time between the suicide occurs and when you get the full reporting, I think you said something like 6 months. It can be 6 months. Is that
in the UK? It can be 6 months on average.
Right.
That's on average.
Right. And so I think you want to be mindful of, if you see the trends going down, what you're looking at is the lag time, I think, from earlier, right? So if it's being reported in March, you may be looking, I don't know what the lag time is in the United States, but you may be looking at occurrences that were prior to March. So I think that's a part of it. I think we also have to be mindful of, as Professor Wilcox said, the ways in which it's categorized, right? And how the medical examiner is making a determination. All of those things take time. And so my first thought when I got the question yesterday, I think it was from Dave from the Boston Globe, was thinking about how much stress medical examiners are under right now, right? Just the COVID crisis is impacting them as well. And so when you think about the categorization of suicide and you want to have a full picture, and you want to have as much information as possible, my thought is, how much information are these folks privy to immediately to allow them to make these determinations? So I think, for my part, I think that's part of why you're seeing some of the suicide rates go down, because we really don't know. And I think as time goes on, it remains to be seen what the outcomes will be. And I think at this point, all we can really do is speculate. I tend to be a more positive, glass half full than glass half empty type of person. My hope would be that we wouldn't see suicide rates rise, because as I said, one is too many. But I don't think we necessarily can say what's going to happen. We can speculate, as was in the Lancet article, about the factors that may be contributing to rises. But I think at this point, that's all we can really do, is talk about what are the factors and how might those factors contribute to increases in anxiety, depression, and potential suicide. But I'll also yield to Professor Gunnell if you have things you want to add.
I don't have too much to say. I agree with all of that. Of course, we often focus on the negatives, and it's very hard to find anything very positive about the current situation we all find ourselves in. But for some communities, it's leading to small geographic communities coming a little bit closer together as they help each other. For people who found work and social interactions very stressful, maybe some of that pressure's been taken off them.
Yes.
There's certainly quite consistent evidence that in times of war, suicide rates go down when communities face a common adversity. So there are certainly pointers why things may get better, but I'd be very, and there's also very clear-cut evidence that during times of economic recession, suicide rates rise. Just from the perspective of how a suicide death is coded, if someone dies in hospital from COVID-19 or from lung cancer or a heart attack, the doctor makes the diagnosis and it's a kind of instantaneous event. When someone takes their life by suicide, there's a coroner's or a police investigation. People are spoken to about the circumstances for the death. They need to rule out accident as a cause of death. They need to rule out murder, homicide. So it's not as straightforward. You don't see the person who's died sadly and just write a death certificate. There's a kind of more protracted investigation. So I'd be quite cautious with interpreting any data that's coming out straight away unless it's from a reliable, real-time monitoring source. There are a few research institutes and counties perhaps that will be trying to identify real-time suicide data. So I think carefully about the quality of those data before reaching conclusions.
Okay, so we'll take a couple more questions. Let me see, I have Aaron Chesson from Berkeley, California, a journalist. Dr. Gunnall briefly mentioned suicide is the second leading cause of death for young people. What are the biggest concerns regarding mental health for the 15 to 19 age population during the pandemic? What are the barriers for young people in at-risk communities to receiving help? And I think, Dr. Alfie, you would be a good one to talk on that also. So either one of you could take a crack at
that. Big question, really important issue. Of course, interrupted education. People's, the next step in their academic career, they might be planning to go to college, university, following school. They might, and those plans may now be up in the air. There may be disruptions to their exams, and they're planning for taking exams and tests that will further their career. So those are all, and of course they're living in lockdown with their parents without so much contact with their friends and their normal social support. So those big stresses. But I hand over to Dr. Alfie to talk about that too.
Yeah, sure. So I think the things we want to be mindful of is, in addition to everything my colleague just shared, we want to be thinking about the ways in which young people, like you think about 18, 19-year-olds, some of these young people may have gone away to college, university for the first year and have had to come back early, right? So there's, as my colleague just said, there's the loss of, I can't continue my education in the way that I had continued it or that I had started it. There's that. There's also this issue that I don't think we talk often about is when you go away to college, again, sticking with these older young people, the freedom that you have to live your life and be the person you want to be. So when I'm thinking about queer young people, freshman year, first year may be the first year they've had to really be free and be out. And now they're coming back into situations potentially where they can't be that free and out anymore. Not always, but sometimes. So I think those kinds of changes to their social structure, right? In addition to, as my colleague shared, just being with their peer group, there may be other peer groups that they've been with for the last year that got cut short because now they're back at home and they can't be who they, have grown into over the past year. I think there's also this issue of the good and bad sides of social media, right? So where are young people getting their information? They're getting it from social media. And so the good side of that is that becomes a mechanism to provide information to young people that might not otherwise get to them. So that's a place where you have lots of organizations, including mine, who are trying to put out information about how to take care of your mental health, how to structure your day, how can you take care of your emotional well-being, how do you recognize signs and symptoms? Because in some ways, unfortunately, you have a captive audience. What are they doing? Their heads are on those phones, in the computers, and in their tablets. And so you want to have a way to communicate helpful information to these young people. The downside is that's where they're getting all their news, right? And so unless you're curating your news, you hop on, there's this wonderful, NBC does a small thing, I think it's called Stay Tuned. They give you all the headlines in 3 minutes. To me, that's a good way to digest news for young people because you get the information you need to know, but you're not inundated with it, unlike people my age and older who sort of sit in front of the TV all day and just consume all the, and it's a lot and it's heavy. So, what I say is that we want to be reporting to young people and talking with young people and reporting about young people in a way that helps to build on the resilience that exists within them, but also acknowledges the unique and extreme stressors that these young people are under. So if we can articulate them and give them mechanisms for managing their mental health, the same is true for other populations, underserved populations, kids of color, again, and queer young people. We want to be able to articulate the unique experiences that these groups are having that often are not talked about, right? And if they're not talked about, people feel invisible. And we want these young people to feel seen and centered. So I think it's a wonderful question. And I'm very encouraging of us finding ways to report about what the needs of these young people are as it relates to COVID and their mental health.
I have a question from Tim Ehrenfeld, who's from Psychology Today, freelance writer who works a lot for Psychology Today. Dr. Alfie, can you call out any groups or strategies that should get more attention so other groups can adopt those strategies?
Absolutely. Yeah, absolutely. So I'll save mine for last, but you already know what mine is. But there's people like the JED Foundation who are working on trying to center the mental health needs of college students. That's a group that I work with to provide the diversity perspective, but they're good anyway. The American Foundation for Suicide Prevention, they have a lot of information out and available. Mental Health America has a wonderful website where they specifically try to center the needs of all kinds of young people and young adults. They're doing a wonderful job. And then organizations like the Boris Lawrence Henson Foundation, which is Taraji P. Henson's foundation, they are giving free virtual therapy to people. So people can sign up through their website and what they're trying to do is center. In the UK, there are two groups that I'm familiar with that I've seen posting on LinkedIn. I think one is called Bright Minds. I'm not sure. If you email me, I can direct you exactly to them. And then there's another new app, I think it's called Smile, that's also through the UK. I think the other one is Young Minds. And what they're trying to do is is that right, Professor Gunnell? They're trying to center this.
Young Minds and Shout is the
Shout, that's what it is. That's right. Thank you for that. So these are groups that I've seen, and then of course the Coma Project, where people are really trying to, across different populations, push information out there that is relevant. I'm a child and adolescent person and young adult. That's relevant for these populations specifically. And I'm always encouraged by the ones that center the needs of the underserved populations. So those are a few.
A couple of the questions. We have a question from Hannah Collins. Will we get contact details for each of the presenters? Yes, we will. On our website, we will link to their bios that has information on their on ways that you can communicate with them. So we will. Yes, you will have that. Question from Dana Edgel. Dr. Breland Noble mentioned the telehealth entity that provides more culturally specific mental health care for racial and ethnic groups. Can you maybe give me a sense again of what is that?
Yes, it's called the Ayana Therapy app. I wish I could remember his name. It's going right out of my head. But if you look up AYANA, I think it's called Ayana Therapy. They are a telehealth app where I think they can do live through the app where you can actually physically talk to the person, and they do chat. So it's like Talkspace for everybody who doesn't feel sort of centered in society, whether that's queer young people, communities of color. And what he's really about, I think he's African immigrant. And so what he's really about is making sure that all kinds of people feel like they have access to care from providers who reflect their cultural background. So it's extremely diverse. It's not just limited to Blacks or African Americans. He has pretty much every racial ethnic group in the United States represented. And you can find him on our Ayana app. And they were featured in Fast Company a couple months ago as a new startup. So they just got up and running, I think, in March. So that's the app. Hopefully that's helpful.
Okay. Finally, I think this will be our last question. Is from Sid Sandifer. It's dealing with economic issues. Question. I understand there's some evidence that evictions are a common precipitator for suicide. In many places now, there are temporary moratoriums on evictions. Do you think this can help mitigate suicide risk from financial instability? And also, do you think the data coming out of the pandemic, given the unevenness of eviction policies across municipalities and states, will be useful for suicide researchers later on?
It's a really important question, and there are a number of ways that financial difficulties may manifest themselves. So paying the rent is one of those issues. Just feeding the family, so access to food banks is an important issue. But paying the rent, paying the mortgage is really important. So anything now that protects families while they're going through an acute, difficult period is likely to be helpful.
Yes, and the only thing I would add to that is that just being mindful of, again, I'm a disparities researcher, so I'm always going to come back to disparities. If there are disparate ways in which people across different racial ethnic groups or cultural groups or gender identity, so on and so forth, if there's a disparate impact on those communities in terms of who's getting evicted and who's not getting evicted, I think that then becomes a really critical and important question. So you're sort of looking at these covariates, right? If people are getting evicted, yes, down the line, we want to look at the relationship between evictions and suicide prevention and suicide rates. I think we also want to be looking at, are there demographic differences in terms of who's getting evicted and what those outcomes are. So from a research perspective, that's where my mind starts to go. And I think as my colleague said, it's a wonderful question. It's an unfortunate question, but I think it's a very strong question that researchers will begin to look at down the line, not solely focused on evictions, but I think that financial impact related to suicide.
I think a really important issue in terms of suicide prevention is, as we've seen in Holly's presentation earlier on, suicide rates are twice as high in males and females. A real issue that blokes often face is they don't like seeking help. There's a certain particular shame associated with getting into financial difficulties. So making sure during tough financial times that there is less stigma associated with seeking financial help. It should be seen as, it's not surprising. We are living in absolutely unprecedented times. We should make the processes for seeking help more straightforward, and we should take away some of that stigma associated with seeking financial help.
And with that, I want to thank Dr. David Gunnell, Dr. Alfie Breland Noble, and Dr. Holly Wilcox, who dropped off a little bit ago, for giving us your time. We're very thankful that you're able to come on and go past our scheduled time to take some more questions. It's very helpful for the journalists out there who are covering these issues.